Good evening, everyone. Welcome to our Life in Motion monthly webinar series. Tonight, we're excited to have both Dr. Biggers and Dr. Norton with us. They both have extensive training and experience on our topic tonight, which is ACLs. Dr. Biggers specializes in disorders of the elbow, shoulder, hip, and knee, as well as all sports-related injuries. He's an expert in shoulder and knee replacement surgery, and he's a member of multiple academic societies and has authored a number of publications, presentations, and educational conferences. Dr. Biggers and his wife Anna have 2 children and love doing all things outdoors. Now, to introduce Dr. Norton. He's an orthopedic surgeon specializing in sports medicine and joint preservation. A former NCAA Division I tennis athlete, Dr. Norton brings a deep understanding of sports performance to his clinical practice. He has several research publications with a focus on ACL reconstruction, joint preservation, and post-operative recovery strategies. Outside of medicine, Dr. Norton enjoys tennis, travel, and spending time with family. Together, they'll explain how ACL injuries happen, what treatment options are available, including when surgery is and isn't recommended, and what recovery truly looks like. Whether you're an athlete, an active adult, or supporting someone through an injury, this webinar is designed to give you clarity and confidence to take the next step. Now, I hope you brought your questions this evening. You can submit those throughout the webinar, through the comments. We'll be answering them at the end in our Q&A session.
All right, so without further ado, thank you both for being here. I'll turn it over to y'all.
All right, well, thank you everybody for tuning in tonight. We appreciate your time, and hopefully we'll be able to share some useful information. Encourage everybody, if you have any specific question at all, please write into us. We really want to answer what y'all want to hear about, and any specific question, whatever it may be, send it in and we'll be happy to cover it during the talk tonight. So just to dive right in, tonight we wanted to kind of just give an overview of ACL injuries. So ACL, or the anterior cruciate ligament, is one of the most important knee ligaments, and unfortunately one of the more commonly injured ones. It's a ligament that's centered in the knee, and it helps prevent the movement of the shin bone on the thigh bone, not only in a front to back motion, but also in a rotational motion. And so an important piece of how we keep our knees stable. Like I mentioned earlier, it is unfortunately a common injury. Some of the data shows up to 400,000 ACL reconstructions are being performed every year in the United States. In terms of who gets an ACL tear, what does it look like? What is the history when somebody comes in? And it's usually somebody that comes in with, feeling like a pop in their knee or have some immediate swelling. And a lot of times we see this in our athletes. I see it a lot in soccer players. We see it in basketball all the time, football as well. Many times it's a non-contact, so it's not like a player is getting struck or hit, but it's more of a pivot move, or when they're going to plant their foot, that it happens. We see some of our football players with a direct blow, so it can happen that way. And then it's not always just athletes either. I've got patients that have had dirt bike injuries or car wrecks and whatnot. We've certainly seen an increase in pickleball type injuries as well. And so we see this injury through a whole spectrum of ages. We see it in our pediatric patients. I had an ACL tear in a kid that was 11 before, and all the way up to grandparents, that are still being really active. So kind of a wide range of presentation, but typically it's an acute injury where you'll feel a pop or feel some swelling on the knee. And if you have walking with a limp, or if those things happen, then it's probably time to come in and get checked out.
And speaking of that, so moving on to the physical exam. The physical exam is a very important component of the evaluation of trying to figure out if you've got an ACL tear or not, right? And so like Dr. Biggers said, typically this is a non-contact injury, not always, but let's say you've had this injury, you're in the office, and what are we going to look for to try to figure out if you have a tear? So the first sign of an injury to the knee is what we call an effusion, which is just the medical word for basically swelling in the knee. Okay, and so that's not specific to an ACL tear. So you could have an effusion of your knee for lots of different reasons, but it's almost never a normal thing to have swelling inside of the knee joint. So that's just kind of the first tip off that there's something going on that's not quite right. If you have, torn ACL, you will likely have reduced motion. Part of that is the swelling that actually, it's occupying the space in your knee, and so that can make it painful to move your knee. You may have an altered gait. And then there's a couple specific tests that we look at. As you can see here, one of them is called the Lockman's test, which basically what you're doing here is the knee is just slightly bent, and what you're trying to do is shift the shin bone or the tibia bone forward or anteriorly relative to the thigh bone. That's what the ACL prevents you from doing if it's functioning properly. And so in a normal knee, there should be a very firm endpoint, what we call it, where you try to shift the bone forward and there's a hard stop, and there's very minimal translation that you can feel. And it's contrasted to that, if you have an ACL tear, there's what we call a soft endpoint, or you can't really feel a good firm endpoint, and there will be more translation than there would be in a normal knee. So that's the most sensitive test really for testing for an ACL tear. And then you can also see here the pivot shift, which is kind of a tricky test to explain, to be honest, but it measures the rotational stability of the knee. And so like Dr. Biggers mentioned earlier, the ACL prevents translation, but also rotation of the knee. And so that's another test we use to clue us in if you may have an ACL tear. But ultimately, the exam gives us a lot of clues, and sometimes it can be pretty obvious from just the exam if you have an ACL tear, but it at least gives us enough clues to move on to the next thing, which is some of the imaging that we look at. Okay, so we do always get X-rays on the front end. Okay, and so most of you may know that the X-rays really just show you the bones and the joints. So they show you, are things broken? Do you have arthritis? So you might say, well, this is a ligament we're talking about. You can't see it on X-ray, correct? And that is right, but the X-ray still can give us a lot of useful information. First of all, like we've mentioned, this is a common injury in young people, and so the X-ray shows us if your growth plates are still open, if you're skeletally mature or not. And as we'll talk about here in a few minutes, whether or not your growth plates are fused or not, whether or not you're what we call skeletally mature, can affect what type of technique is used if this is something that we operate on. So it's important to know that information from the X-ray. It's also important to know if you have any arthritis, because that's actually a reason that we may not do an operation for your ACL if you have a lot of arthritis. So it is true that typically the X-ray is not going to tell us if you have an ACL tear, but it does give us important information for the whole clinical picture. But ultimately, the thing that does give us the definitive answer is the MRI. And so, like I said, the MRI shows you all the soft tissues that the X-ray doesn't show you, the ligaments, the tendons, muscles, nerves. You can see lots of things on MRI that you don't see on the X-ray. And as the slide shows here, you'll see a discontinuity of the ACL fibers. You can see in the top left picture here that thick band of black tissue that's running kind of across the screen. Hopefully I'm explaining that well enough for you guys to know what I'm talking about here. But that's the ACL, and you see the picture right below that. It's gone. You really can't even see the fibers for the most part. And so sometimes the MRI will like that, where it's almost like the tissue is no longer there. That can happen in chronic injuries. And then The picture in the bottom right, you can see those white areas where the arrows are what we are the bone bruising pattern that you typically see with an ACL, and that's basically just swelling in the bone that results from the shift of the knee that occurs when you have this injury, and that clues you in that there's a tear, and it also lets you know that this was probably a recent injury. So yeah, the MRI is what we definitively tells us about an injury here.
Yeah, and I completely agree. I think the Lockman for me is probably the go-to test. If I'm worried about somebody, whether it's covering a football game or out on the soccer field or in the clinic, if I'm worried about the ACL, the Lockman's kind of the go-to test. And for the most part, when you're examining somebody, if they're able to relax, I kind of know, whether or not they got an ACL tear without an MRI. If they're really painful and guarded, sometimes it's hard to get a reliable exam. They can contract the hamstrings, and they, then you just can't really feel that translation. But if you get a patient to relax, anybody that's been trained in sports medicine, can have a pretty good idea of whether it's torn or not just on a physical exam. What the MRI also does for us, is let us know the rest of the knee. Unfortunately, when you tear your ACL, sometimes you tear some other stuff too, like the meniscus and some of the other ligaments. We essentially always get the MRI just to confirm our physical exam findings, but not only that, we also want to know kind of the status of the other structures of the knee. So if we're talking about surgery, we'll kind of have a full game plan as to what we need to do to take care of the patient. So it kind of leads to what do we do, how do we treat this? I've already mentioned kind of surgery, and we don't operate on all these. There's certainly roles for non-surgical management in situations. If there's a partial thickness tear, where it's not a complete tear. If it's maybe a patient that's older and not as active or is not looking to return to a cutting, pivoting type sport. Those are situations where we kind of consider non-surgical treatment. And so that would look like physical therapy, really. You'd want to try to acutely, you just try to control the swelling and inflammation. So, ice, compression, anti-inflammatories, like any other injury. And then, there's some role to increase the strength of the muscles around the knee that kind of provide some additional stability. There's even, you could consider some ACL bracing as well for the people that wanted to opt for non-surgical management. And then, modifications of your lifestyle, in other words, stop doing whatever it was that caused you to tear. So if you were playing a pickup game of basketball and you said, look, I'm just done with basketball forever, then that could be a reasonable thing. But for the most part, treatment's going to be surgical, at least for the patients that are wanting to maintain that same level of activity. So if you tore snow skiing and you want to go snow skiing again, we're typically talking about fixing it, whether that's when you're 12 or when you're 60. Like I mentioned earlier, there can be some factors that would keep us from being able to fix it. If you have a tremendous amount of arthritis in your knee, we say, well, your knee's too far gone. But typically, when you have that much arthritis, you're not doing the kind of sporty type activities that have led to the tear in the first place. And so, surgical management. We talked about reconstruction. Didn't say repair, and a lot of people kind of switch those two words out and say, "Oh, I got my ACL repaired." And some people are doing that. It was back, I think in the 70s, there's kind of a push to repair things, which is kind of sewing the torn pieces. But that MRI that Colton showed earlier, you looked at the fibers of it, and it was all just kind of torn apart. It wasn't like just one piece that was kind of cleanly torn away. And unfortunately, that's really how most of the ACL tears are. So there's a small section where there's just kind of like an avulsion where you could sew that piece back together and actually do a repair. But by and large, when we're talking about ACL surgery, we're talking about making a new one or reconstructing it. And so kind of the big picture, or kind of overall view is, where do we get the tissue from? If we got to make a new ligament, we got to get the tissue from someplace. The first thing think about is, do we get it from you or do we get it from somebody else? And so an autograft means from you, or an allograft means from a cadaver or a dead person. And so that's kind of the first thing I think about when I'm having a patient in clinic is, which bucket do we fall in? And, I think different grafts for different people. I don't really think this surgery is a one size fits all. And I think there's some utilities, pluses and minuses to each, but feel pretty strongly that the allograft is the wrong answer for young patients. And so in my clinic, if you're younger than 20, that option's off the table. I'm just not going to do it. And the reason is because there's been some good literature that showed that the failure rate is way higher if you use cadaver tendon in young people. So really super active young people, autograft, right?
Yep, totally agree. There's, like Dr. Bigger said, most things when it comes to grafts with ACLs are somewhat debatable when you're talking about, hamstring or quad or bone or BTB. But the one thing that I think is kind of not really debatable is what he just said, which is autograft or your own tissue if you're a young patient, 20 or less for sure. For me, even into your 20s and 30s, probably offering you an autograft, but the lines start to blur the older the patients get. But as far as the literature and the research shows, less than 20, you should have your own tissue.
Yeah, for sure. And and then there's from an autograft standpoint. So if we're going to use your own tissue, what tissue are we talking about? All right, so we can use your patellar tendon, which has got a little bone plug on each end. We could use your hamstring tendon, or we could use your quad tendon. So those are kind of the three mainstay grafts. Well, history lesson, the bone patellar tendon bone, that's kind of the old school, the tried and true, the gold standard. That's what's been around the longest. That's what we have the longest literature support of. It's been done for a long, long time. Hamstring is probably behind that in terms of the longevity of the research. And then kind of the new kid on the block is this quad tendon, which is getting a whole lot of press and pretty favorable research coming out with it. But I think all three of those grafts are really, really good. And probably the most important thing is, honestly, the surgeon that's doing it, that does a good surgery and that does it well and, executes the operation how it's supposed to be. And most of the studies are going to tell you the failure rates probably are as dependent in how you do the surgery, where you put the tunnels, and executing the operation, as they are if you use a quad versus a BTB or a BTB versus a hamstring. So a little bit, I do think there's some circumstances where one surgery is a little bit better than the other one, but they're all really, really good surgeries. So in my own practice, I use a bone patellar tendon bone for anybody that still has a jersey. So if you're playing on a competitive team, like I said, if you got a jersey, whether it's high school, college, for really high level weekend warrior types, I do a bone patellar tendon bone. One caveat to that is the skeletally immature. Colt was talking about the x-rays earlier. And, if you have open growth plates, that graft is off the table. So when we have open growth plates, we got to make sure that our surgery doesn't compromise future growth. And if we drill holes across the growth plates, which you kind of have to do to some extent, well, not exactly. You can do it on epiphyseal, which is our very young patients is what we do, but we can alter the technique depending on the growth, but we always use a soft tissue graft when we're doing it on a skeletally immature patient, which a soft tissue graft would either be the hamstring or the quadriceps. But so soft tissue grafts on young people, for me, I use kind of bone patellar tendon bone in kind of the competitive athlete. I just like that it's got the kind of early bone incorporation, that rigid screw, and for me, it just feel like it can feel a little bit tighter, a little bit quicker. But there is a downside. Why don't I just do it on everybody? Well, there's a little bit higher instance of anterior knee pain. When you can't kneel, it's a bigger incision. And, so it's not right for everybody. If you're already having some pain going up and down stairs and, you got a little crunchy knee, then that's probably not the right graft for you. And then, once you get in, 30s and 40s, I still favor autograft as well, in that age. And then, I do a lot of quad tendons now. I still do some hamstrings. I think the literature's continue as the more we learn about the quad tendon, it's all, it's sounding good, but, I still think, the long history of hamstrings around, I think that's a good graft too. So, what are your thoughts?
Yeah. My, the usage of grafts in my practice is very similar to what Dr. Vickers just said. I do primarily quads, and I'll do BTB on some occasions. I'm probably not doing BTB as often as what Dr. Vickers mentioned. Not necessarily everyone with the jersey for me gets a BTB. There is some good literature showing that even in cutting and pivoting athletes, quads can be just as good, but the orthopedic research is complicated. You can pick and choose an article to kind of show, what you're looking to show. So, but I think that quad and BTB are both very good grafts that I use. I don't do very much hamstring, not because it's not a good graft, but if I'm going to use a soft tissue graft, it's probably going to be a quad for me.
Sure.
And I will do an allograft on occasion, not on young patients like we said, but I do think one thing that's important to mention is, you might ask, well, why would you ever use an allograft? What's the point of that? And so, when we do perform a harvest, when we get the tissue, there's morbidity in that, right? We take your quad tendon, we're taking a strip of your quad. It takes a while for your quad to come back. If we do a bone patellar tendon bone, we're taking chunks of bone, out of your leg. So, that's the reason that, I'm not sure if we mentioned that yet, but, and the patients that I've done allografts on, it is noticeable actually, their first couple post-op visits, might be a little bit easier, pain-wise and swelling-wise. So, it can be tempting when you see that, but, it's still only for older patients, I think.
Yeah, to your point, I had a patient the other day. She was 6 weeks out from an allograft in my office, and she's like, "Hey, I'm going to go play pickleball this weekend." Yeah. And I'm like, "Whoa, no, we're not.
Right.
We're nowhere near ready for that." But it was like she wasn't hurting because she didn't have the extra, So to your point, if I've got, say a business person or somebody, that's needs to rejoin the workforce in a really quick manner, and they're like, "Look, I just can't be off work and be tied up at home and all this pain." I think allograft sits in there, and while I truly don't believe the allograft is quite as strong as the autograft, many times it's strong enough,
right?
Because if we're not getting back to being a inside linebacker, or a midfielder on the soccer field, if we're looking to just go play a little backyard ball or go golfing or whatnot, then many times I think it's strong enough.
Yeah.
And it certainly has the added benefit of not quite as much post-surgical pain. And now we kind of have some fancy little techniques, the internal brace. I think you're doing that as well.
Right.
We can augment these allografts, and probably make them a little bit stronger.
So while y'all are on this topic, we have a guest who's watching, Jason. He asks, which of the grafts are easier to do?
Yeah, I think good question. And maybe what I'm hearing is which of the graft is easier for the surgeon to perform?
I guess you can answer like which one is easier to perform and then which one is easier to recover from as a patient.
Yeah, so you're right. That's probably more what they're asking is what, from a.
I thought the same way as you.
So, yeah, it's all about there. Yeah. So from, a couple of things. So I think, and again, what I mentioned earlier was I think you want to have the surgeon that's performing your surgery be super comfortable and confident with the graft at hand. And not everybody, like I've got a friend in Chicago, and like everybody there, like he trained here in Memphis, then went to Chicago, and like they did no bone patellar tendon bones. Even they took care of the professional football teams there, everything was hamstring. They did a really good job with it, but it was just regionally a different graft. And so I think first and foremost, you want your surgeon to know what they're doing with that particular graft. But from a patient perspective, is there a difference between having your quad harvested versus your patellar tendon harvested, versus your hamstring versus allograft? I mean, yes, there is. I think the quad tendon, harvest, you're going to have a little bit longer return of your quad strength, and the hamstring tendon, you're going to have a little bit longer return of your hamstring strength. And that kind of just makes sense, right? From the allograft, as we've mentioned, that's going to be the easiest to recover from, just because it's less surgery. We're not having to make extra incisions and to take extra tissue. So it's a trade-off. But for somebody that's, again, not competing at a high level, I think the allograft is certainly a reasonable thing to do. But deep down, I think it's probably not quite as strong. And so it just kind of depends. If we're kind of going all in, is it worth a little extra pain for, the 2 to 6 weeks, that you're going to be hurting to maybe get that stronger tissue? And for a lot of patients it is, but for not everybody. And that's why this isn't kind of a one size fits all approach. We kind of have to take every patient where they are and just kind of explain the kind of the pluses and minuses of each different graft. The other thing to think of is, future surgeries. I also do a lot of knee replacements. And so I've seen previous ACLs now from people in their 70s and 80s, and just kind of some wacky incisions and different hardware. And you also got to think about harvesting, whatever particular area, patellar tendon or quad tendon, could that affect something down the road too? And so, as patients get a little bit older, sometimes we think more about that too, and kind of have that weigh into the decision. But I don't think, I guess a lot to say, I don't think there's a drastic difference in the post-operative recovery, in terms of pain, between really the 3 autografts, or at least I hadn't seen that in my experience.
Yeah, no, I agree. And, the easy answer, like Dr. Bigger said, is the easiest to recover from is allograft, for the obvious reason that we're not taking your tissue, right? But like we've been talking about, most of the time, most people aren't the best candidates for that. So when you're talking about an autograft, a lot of this is kind of pain related, and pain is a hard thing to quantify, right? It's subjective, only the patient can feel their knee, no one else can. So it's hard for studies and research to capture that. So I think Dr. Biggers is right. I don't think there's an easiest one. I think they all have their own challenges, and it's hard to say, to be honest. Other than the only definitive answer here is allograft is the easiest to recover from, but as we've mentioned, it has its deficits. So,
can a patient, once they've decided on surgery, can you walk through what the recovery process looks like from day 1 of surgery to however far out until they're completely recovered?
Yeah. So typically, and everybody's rehab protocols probably varies a little bit, but for me, I put patients in it's called a post-op brace, but it's kind of this big long braces that's got a hinge on it. And you're going to be walking in that locked in extension for the first couple weeks. Whenever you have your surgery, whenever really you put water inside the knee, you get a little bit of quadriceps inhibition. So the quad muscle just shuts down and you just have a little bit of instability in your gait. So you're on crutches and in this brace, but weight bearing is tolerated. And I think that's an important point. Back again, history lesson back in the day, they used to put people in a cast for like 6 weeks after the surgery. And, it turns out they got a bunch of really stiff knees. And so we know now that that's not the right thing to do. Your weight bearing is tolerated out of the gate, day 1 with crutches and a brace. Caveat to this, depending on what the status of the meniscus is. Again, we talked about earlier, sometimes you can have a meniscus tear at the same time that you have your ACL torn, and that can vary the weight bearing status. Many of the meniscuses that we repair, we actually will still allow them weight-bearing extension. If it's a peripheral tear, weight-bearing actually helps compress the tear and you kind of reinforce your repair. But if it's like a radial split or a root tear or a more complex tear, then sometimes we have to restrict the weight-bearing. But strictly speaking, for ACLs, your weight-bearing is tolerated. Start physical therapy pretty quick for me. I get them in therapy 24 to 48 hours after surgery. Therapy really is crucial to a successful outcome. I really kind of push early extension. I want them to really get that knee straight as quickly as we can. We're shooting for symmetric range of motion. I want to get the motion back to how it was. We're going back to normal. And if that means an extra couple of degrees of extension, then that's what we shoot for. You're in therapy, typically about 3 days a week. And usually, that's the better part of 12 weeks or so. It kind of depends on the insurance plans and stuff. Sometimes we can only do 2 days a week, but we kind of modify that as we need to. So I don't know, what about you?
Yeah, my protocol is almost the exact same. And I think you make a good point. Something that I emphasize to patients is, for whatever reason, I think when we're starting therapy, there's everyone likes to kind of see how far they can bend the knee, right? And so, most of the time, patients don't have a hard time getting their flexion back. And if you did lack 5 or 10 degrees of flexion at the end of your course, it's probably not going to be the end of the world to you. But if you lack 10 degrees of extension, it can be pretty devastating to your knee. So I would say a definite emphasis on getting the knee all the way straight. You can kind of gauge that, if you can slide your hand behind your knee on a table, it's not going all the way flat. So, even 5 degrees or so can inhibit you a lot.
Yeah, Dr. Shulman's got some good literature out on that, but it's not being able to get your knee locked out straight is a really, really bad thing. And so, unfortunately, with some surgeries that we do with the knee, you can develop some contractures. And, I always tell patients, let's prioritize 3. Prioritize our rehab and let's kind of check it off in order, but let's get it straight, let's get it bent, and then let's get it strong. We got kind of all the time we want to get it strong, but the motion, we're kind of a little bit racing on the clock versus scar tissue and stuff setting up. So,
But I also, for isolated ACLs, let patients weight bears tolerated with the brace locked straight for 2 weeks, and then I let them weight bear tolerated with the brace unlocked after the first couple weeks. It's a lot of therapy, like he said, and the concomitant injuries changes things a lot, like Dr. Bigger said. So for meniscus tears, for me, if it's any kind of radial tear or root tear or complex tear, you're probably going to be 6 weeks non-weight bearing for me. But it's the meniscus that dictates non-weight bearing. I'm not, I wouldn't have you non-weight bearing just for the ACL.
And sometimes with meniscus, we'll slow down the motion too. A lot of times we'll start
90.
0 to 90, which is why a lot of times when you got a meniscus repair, you're going to be a little bit stiffer too. And so occasionally I have athletes come in and they're like, well, I was at therapy and so they've already got to 120, and they're like, this isn't fair. And it's like, well, it's kind of apples and oranges comparison. If we got a big meniscocapsular junction repair that we've put some stitches in, and we weren't letting you bend your knee past 90 for the first 6 weeks, you just kind of start behind, but we all they'll end up in the same place.
Right. And I think some of the milestones sort of that patients might think about, for me, I'm letting you start some controlled straight line jogging at about 3 months typically. And then as far as, what we call plyometrics, or just kind of starting to get back into the cutting, pivoting stuff, would be probably the next visit after that, kind of like 4.5, 5-ish months, start doing that type of stuff. And athletes will fit them for a return to play brace, in 3 to 4 months ish, which is, a brace you wear when you're getting, it's different than the post-op brace. That's a brace you actually are getting back to sport in.
Yeah, that brace, you kind of measure the quad, and if anybody's been around somebody that had ACL surgery, you'll note that like when you look down at their leg, the muscle just withers away, and it really is kind of remarkable. At 6 weeks and really even 3 months, you just look at the difference in the size of the legs, and they're pretty drastic. But you want to wait to get that brace until that quad muscle starting to get back to a reasonable size. That way you don't kind of outgrow the brace as you finish up the rehab. And truthfully, I do the exact same thing. I have asked my athletes to wear one of the ACL braces for their first season back. Although admittedly, there's not a great amount of literature support to that. There is, if you dig down in the medical science of it, it says it doesn't really matter. But I
Makes you feel better.
In my experience, it makes me feel better, and I think it makes the athlete feel better too, or at least that's what I've seen. And truly, the return to sport, there's a big sports psychology part of this too. And so, not only do we got to get the knee right, we got to get the mind right too. And I think sometimes just having that brace can kind of give us a little more confidence in the knee. That being said, whenever I have, certain athletes, if I got a cheerleader or something that's a flyer and she comes back and she's like, man, I just can't wear this brace because I can't compete, then I'll let them kind of have a pass, and compete without it. But most of my contact athletes, I certainly recommend the brace as well.
Yeah, I agree with that.
Now, do y'all have a time frame of how long after the injury someone can have a reconstruction?
Yeah, I think that's a great point, and certainly they looked at a lot of this. Kind of when I was a resident, I think there were some people that would go out snow skiing and get tear their knee, and then they get fixed before they got home, and people thought it was kind of crazy. But I think the most important thing is not necessarily a set length of time. It's not like you got to wait 6 weeks or 2 weeks. What you need to do is regain normal motion. All right. So you heard us talking a lot about the rehab earlier and how important it was to get your knee straight. You want to be going into surgery with a full tank of gas. You want to make sure that you got normal motion or close to it at least before you go into surgery. And so if I've got a patient that tore their ACL, a week ago, and they came in my office and they can get it all the way straight, and they got 120 degrees of flexion, then I think we sign them up for whenever they want to go. If I have a patient that comes in and they're just limping around, they're on crutches, they're hardly want to put weight on it, it's just super painful and inflamed, you still got that real inflammatory response going on, that's probably somebody that needs to kind of chill out a little bit, let that response kind of calm down. A lot of times we'll go into prehab, which is just go into physical therapy before surgery, just to help kind of get that motion back.
No, I agree with all that. Was the question framed like, is there an amount of time that's too long? Is that kind of what they're? So, I think the short answer to that is kind of no, honestly. If unless you have some other factor that's that is preventing you from being able, if your knee's eaten up with arthritis because you tore your ACL a long time ago or something like that. But
yeah, it's probably unknowable, but how long is too long? Well, too long is waiting until you had another subluxation event.
Right. Yeah.
If you need to do it before you have that next subluxation event, and anytime before, that's fine. But we don't know when that next subluxation event is going to be. But when that shin bone shifts forward again on your thigh bone, then you're kind of tearing up the cartilage again in your knee. You can have a higher risk of meniscal injuries, and we only get one set of cartilage in a lifetime. And so, that kind of goes to like when I was in high school playing football. I had a guy on the team. He tore his ACL halfway through the season. The team doc was like, "All right, put a brace on it, be fine. We'll fix it at the end of the season." And nobody does that now. And the reason is because more instability and you tear up your knee.
Right.
And so I think for pretty much everybody, I would say, an ACL tear is kind of you're out. No clearance for return to play. And then you have to cancel next week's vacation to go get it fixed. No, you don't, but you're gonna have to alter your activities. I've certainly had patients come in, they tore it, and they've got a trip coming up. Maybe they're going to the beach or something like that, and you say, look, you just got to be careful. You can't get out in the waves. You can't, jump around, because we just don't want to have another subluxation event.
Right. Yeah, and let me clarify. I certainly wasn't saying you should wait to do it. My point was if you're a patient who, for whatever reason, you tore your ACL a year ago, Yeah, and you're like, oh man, is it too late for me? My point is, I mean, no, I mean, you can still have it reconstructed. It's just,
Yeah.
You shouldn't wait, but if you have whatever the circumstances are, it's not like, oh, I missed my window, because like we talked about, this is a reconstruction. We're rebuilding it. It's not, there are certain injuries in orthopedics, tendon tears and things that are very time dependent, that where, you miss your window, sometimes you kind of can't have an operation done. So I don't want you to think you missed your window of opportunity to have an ACL reconstruction.
Yeah, completely agree with that.
Is there an age cutoff?
No, I mean, no. I guess the short answer is no. There's certainly an arthritis cutoff, and as we get older, we're more prone to develop an arthritis. But look, I've done ACL reconstructions on people in their 60s. They come in, they're super active, they're playing a lot of sports, like I mentioned earlier, pickleball. I've had a lady recently that, she tore her ACL playing pickleball. And she's like, look, I love this. We're doing it for our grandkids. We want to get out. I'm not ready to hang it up. So should that person not be able to have an ACL reconstruction? I think, in my opinion, they should. Get them back to what they're wanting to do. That being said, if there's somebody that comes in that's not doing sporty activities, and they've got more of a degenerative ACL tear that's had some arthritis in their knee, that person doesn't necessarily need their ACL reconstructed. But yeah, if you got an active person that's that's a little bit older, I still think they're appropriate to reconstruct.
Yeah, I think totally dependent on activities and goals and what you're trying to do. So yeah, there's not a specific, your birthday was yesterday, you're this age, can't do it. That's not how we evaluate it typically.
All right, so I have two questions left, kind of different from each other. The first one is, how long does it take to perform the surgery, like in the OR?
Yeah, it kind of really just depends. I mean, the true answer is it takes as long as it needs to take to get it done correctly. And I tell patients that all the time. But I think typically, an hour to an hour and a half would be. The allografts are going to be a little bit faster because we're not having to do that second part of the surgery where we're harvesting tissue. Sometimes we have assistants in there that are kind of helping us do graft preparation and stuff. Sometimes we're doing everything on our own, and that can affect the time a little bit. Mm-hmm. But yeah, less than 2 hours, usually around an hour or so.
Mm-hmm.
And the meniscus stuff can also add a little bit of time.
Right, that was my main point. Yeah, I mean, sometimes you're doing kind of 2 or 3 kind of separate operations. If you're repairing both meniscus, which can, you can have both meniscus torn, you can have, we haven't talked about the other ligaments in the knee, the MCL, the LCL, you can have what we call multi-ligament knee. So if you're talking about just an isolated ACL, yeah, I think hour and a half maybe, but you can certainly get into longer cases just depending on what the other injuries are.
And the last question is, we see athletes going back to competitive sports, even, the most competitive. Is there a time where you would recommend a patient not return to their sport?
Yeah, not for me. That's kind of the whole reason that we're doing it. And so I'm not a big fan of putting restrictions on people when, whether it be doing an ACL or total knee or total shoulder or whatever it may be. I think we try to get them back to motion in life and doing the things that bring them joy, and certainly counsel them about risk. And so if you've torn, now this is, say we got an athlete that's torn one ACL and now they're seeing us for the second ACL that they've torn and they're looking to return to sport. I've got a soccer player right now that's in that exact boat, and she's kind of wrestling with, she's playing college soccer, and she's like, how do I really want to go back or not? And, I completely, put the ball in her court. I'm like, look, we've given you this knee. It's stable. It's good. It's stronger than it was before you've torn it. Interesting fact, when you tear your ACL, you're actually twice as likely to tear the other knee than you are the one that we reconstruct. We reconstruct it stronger than it was. But no, I don't, I think sometimes when you have like lateral meniscal pathology, so a tear in the meniscus in the outside part of the knee, sometimes those patients don't do quite as well. But even when that injury is present, I'm not restricting them from going back, just kind of warning them that they may have some discomfort associated with it.
Yeah, that's well said. I totally agree. I mean, the only scenarios where I think as sports medicine docs, we start, kind of maybe advising against play or things that are, life-threatening stuff or, head injuries or, bad, neck injuries on the field. Those are kinds of things where, you start, talking about should we be doing this. But for your ACL, like Dr. Bigger said, I mean, that's what we're here to do, is to try to help you get back on the field. So, I can't think of a scenario where for an ACL tear, I would advise someone not to go back. You just talk to them about risks of re-tear but ultimately that decision is up to the patient.
Awesome. Well, I think that's all we have. Do you guys have any final thoughts before we close out?
Yeah, the length of time to return to play is a lot of, I get a lot of parents and athletes and, that want to talk about that. When can we get back? I'm in the office, I tore my ACL, am I going to be ready for next season? Or I'm a baseball player, I got football season coming up, how soon is too soon? And, if you go to these orthopedic meetings, or if you're talking, the huddle, or if you text your fellowship class and you try to figure out, what's the right answer. And the truth is that there's a lot of variation. I think the range typically is somewhere between 6 and 12 months. I think it's truly more individual, just like the surgery needs to be individualized, the return to play also needs to be individualized. And we're not necessarily looking at a certain metric in terms of time frame. We're looking to see where the athlete is in their function. So full motion, full strength, no pain, and that can go for a lot of return to play criteria, whether you got an ankle sprain or knee sprain, or, if you can answer yes to, you got full strength, full motion, no pain, those are pretty good indicators that you're ready to get back to sport. I do think, it used to be 12 months and went down to 9 months, and it was 6 months, and now the kind of pendulum swinging, maybe back towards 9 months. In terms of just the average length of time, I think the truth is that if you go back when you're not quite strong enough, then there's a higher risk of re-injury. And so I think that's the biggest thing, is that we want to get about 90% the uninjured side, in terms of strength. And there's a lot of different ways to assess that, whether it's a functional screening exam in the room, or, some fancy tests at the physical therapy clinic, or old school, just measuring the size, the circumference of the quad, the leg. But really, the driving factor of the time, return to play is when we get that strength back and, somewhere close. And so I think as long as we got that strength back, then, whatever time it is, whether it's 6 months or 12 months, then I think it should be safe to return.
I'm very similar in my thoughts. I mean, it does make me feel better to be 9 months, if there's not a specific, trying to get back to this season or this, specific event kind of thing, then I kind of encourage, 9 months, because why accelerate it if you're not trying to get back to a specific thing? But ultimately, I'm open to it being closer to 6 months, just based on the objective things that you mentioned. So, if you've got normal motion, you've got 90% strength to the contralateral limb, and, no pain and no swelling, then I'm okay with, going back. So,
and it's, for me, it's always kind of nice to just kind of set that out. And just like your high school class, you kind of had some rock stars that kind of hit it out of the park, and you'll have some patients that kind of cruise through, and like I'll see them in 6 months, and they're like, wow, I mean, they're equal strength and doing great. And I'm kind of like, I'm hard pressed to hold this person back, like they're just jumping at the bit to get out there, and I think that's fine too. The other side of the coin is, you got somebody that's a little slow in the therapy, maybe they just kind of weren't into it as much, and you see them at 9 months, and you're like, wow, it's still really weak. It's like we probably need to slow that person down to 12 months. And so, I really think basing it on the individual recovery, it kind of depends on, to some degree, how hard they work to get back.
Sure.
But for sure, if it's
weekend warrior type or certainly a revision situation where we're having a redo, it'll typically slow it down a little bit.
Awesome. All right. Well, if y'all don't have anything else, we'll close on out. Thank you everyone for watching and participating tonight. If you would like to make an appointment with Dr. Biggers or Dr. Norton, all of that information will be posted in just a moment. Have a good evening and we'll see you next month.
Thanks for joining us.
Thanks, everybody.